And today, as you'll know from the programme, we've got a focus on vascular access. And this is an area of practice and care that is increasingly important to me as I've gone through my career. I've been in a really privileged position in 2 organisations to lead a vascular access expert team that do brilliant things throughout the organisation. I mean, these folks are magicians. The things they can do with their fingers in terms of putting in lines that nobody else can do. It's truly remarkable, and I'm fully convicted in my mind that the work that our vascular access team does makes our organisation considerably safer for our patients. However, they are a small corporate team in an enormous organisation spanning 5 main inpatient sites with a full range of services. So having a single small corporate vascular access team cannot mean that we have good vascular access throughout the organisation. It has to be something that is fully embraced by everybody who works here in this trust. It's a little bit like the IPC agenda, really similar scenario. We've got a relatively small corporate IPC team, and we're trying to get these vitally important messages about prevention out to the entire organisation. So why do I think vascular access is really important and it really matters? Let me tell you a story. Not so long ago, this organisation admitted an 89-year-old man through the emergency department. He was admitted after a fall, and in the emergency department, a peripheral vascular access device was inserted in his antecubital fossa, in the kind of crook of the elbow. Now, turns out that device was never really needed in the first place. It was put in just in case. And the shocking part of this story is that essentially the team looking after the patient forgot about this line. There was no reviews, there was no documentation. And only 7 days later, when the line was looked at and somebody thought, that doesn't look so good, there was information around the insertion site and a little bit of pus. And it was the signs of a staphylococcal bloodstream infection. And the tragedy is that this man died as a consequence of that bloodstream infection that was linked directly to the line that was inserted. So the poor man died from a line infection from this vascular access device that he didn't need in the first place and wasn't taken care of. And that's a tragedy. And we tried to learn from it. We tried to share that learning. But that's just one example in this broad organisation of where vascular access has gone wrong. And it's not completely uncommon to identify issues with line care when we do our reviews of bloodstream infections, etc. And even go around the hospital, have a look with your own eyes, you'll see poor practice with vascular access devices. And these are connected to our patient's bloodstream. They're really high-risk devices. And they're really, really common. So if you look at any point in time, around about 40% of patients will have a peripheral vascular access device and around 7% will have a central line. But actually 70% of inpatients will require a peripheral vascular access device at some point during their stay. So 7 in 10 patients. It's difficult to imagine an intervention that is as universal as this. It's something that many of our patients experience. The projected vascular access market is huge, and we're not interested in the financials today, but just in terms of the volume of devices, 7 of 10 patients have a peripheral vascular access device today. I expect that's going to increase, and also the complexity of the vascular access devices that we're using over time is going to increase as well. If you just look at peripherally inserted central lines, they've come from nowhere in a relatively recent period of time to be an incredibly vital part of our healthcare delivery. And that trend, I'm sure, will increase. There's another trend that is almost certainly going to increase, and that's related to our patients. Now, who are these? Divas, I hear you cry. Not these kind of divas, but patients with difficult intravenous access. This is a trend in medicine that is increasing as our patients get older, as their needs become more complex, as their vasculature becomes more broken down because of everything else that's happening to them. It becomes increasingly difficult to either access and maintain access to their vascular system, which we absolutely need for so many of the things that we do with our patients. We know that patients with DIVA do worse than patients with normal vascular access. You can see from this chart here that patients with DIVA were slower to get medication, slower to get IV fluids, slower to get laboratory results, slower to be admitted, and slower to be discharged. So DIVA really is a problem for these patients, and it affects many aspects of their care. So why is vascular access important? Well, we've talked a little bit about patient impact, so the healthcare associated infections that can result from poor practice related to vascular access. Sometimes even not from poor practice, sometimes just from the fact that we need to put a vascular access device in. That can be enough to result in a healthcare associated infection, even when things are done well. We haven't talked about the patient experience though. If you talk to patients and say to them, what was the worst part of your care? Often it's multiple attempts to get vascular access. Patients hate that, and you'd hate that if you were in hospital, and many of you will have had that experience. We've noted treatment delays, and they can be worse for patients with difficult access, but it's also additional use of resources. So if we need to take a consultant anaesthetist out of theatres in order to insert a line, or an interventional radiology suite out of practice to insert a PICC line, then that's a significant resource that could have been used elsewhere. We also need to be mindful of clinical complications, and we'll look at those in a minute, aside from healthcare associated infection. There's also litigation and reputational damage related to vascular access. There's been some cases where trusts have had to pay out to successful litigation, and sharp injuries for staff can occur if vascular access is done poorly. So in terms of clinical complications, this is a review and meta-analysis of the data. Infiltration was most common, phlebitis, followed by occlusion, dislodgement, and infection at the bottom there. You can see it's tiny, relatively, to complications on peripheral vascular access devices, but obviously very impactful. But taken together, what these data show is that around 50% of peripheral vascular access devices will fail at some point before the end of their life due to issues and unintended consequences. So there's a really high failure rate, and that then means you need to reinsert or resite the device, and the process starts again. There's also significant costs attached to these issues, particularly infection. The average cost for a catheter-related BSI, according to HRQ, which is an American agency, was around £56,000. That's a single catheter-related BSI. Obviously, the individual cost will be higher or lower than that. That's the average, but it's a lot of zeros, isn't it? So thanks to Jane for these images, and they're shocking, aren't they? Really, if we look at the impact of these issues on the patient and think about how you'd feel if you were a patient looking down at your arm or your leg, and this is what you saw, especially if that was as a result of poor or less than perfect practice. I understand the extravasation injury in the top right was actually a member of staff who was young and had this terrible extravasation injury, which was to an extent life-changing. And these are pictures of real patients and real practice. So what I'd like to do for the rest of our time is think about two slightly different angles on improved vascular access. One, on a very individualized patient care. What can we do to make things safer and improve care? And secondly, more on a kind of organizational improvement level. How can we begin to make progress as an organization? So I want to think about this, the hub, the connector, which is required to connect whatever you're putting into the vascular access system with the permanent fixture of the vascular access device. And you can see from this schematic that there are several sources of potential contamination of the hub. One is the kind of hands of a healthcare worker. Maybe it'd be nice if that hand was ungloved, but that's another story. And the other is contamination from the inside or the outside of the hub itself. And so we recommend that the hub should be disinfected prior to access. However, what do you think the overall compliance with what is often called scrubbing the hub is when we looked at a kind of across a range of healthcare professions? And I think this is probably realistic. So if you had to choose the percentage compliance with scrubbing the hub prior to access, what would you say it was? Talk to your neighbour, have a chat, have a think. What percentage compliance with scrubbing the hub do you think we would see in practice? I bet nobody gets it spot on. Okay, so the answer is 39%. 39%, less than half of the times that these hubs are accessed. Is there any disinfection of the hub? And I mean, you know, that's a significant limitation of these kind of data. They weren't looking at compliance with the full 15-second scrub, 15-second dry. They were looking at whether there was a scrub at all, a little bit like a hand hygiene audit. We don't tend to assess compliance with technique when we audit hand hygiene. We just say, was there a squirt of gel at all? And it's similar here. And when we look at hub disinfection and whether we're doing it for long enough, this was a study from the States that showed a baseline evaluation. The average time was 10 seconds to scrubbing the hub. Following education, it was over 20 seconds, but only when they got a timer out and put it on next to the patient and said, right, I'm starting my scrubbing the hub now. Beep, 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 beep. Now I can finish. Did they get compliance with their recommended 30-second hub disinfection in this study? So this is a nice potential for the adoption of some technology, which I love. I'm quite a technophile. Given the choice of improving technology or improving human behavior, technology is the better choice. And you know, I don't necessarily think this is always true, but very often it is in my experience. And I think there's an example here where we can adopt some technology. So rather than trying to get really good compliance with scrubbing the hub, we can adopt a passive disinfection approach. That's where you get an alcohol-containing cap that goes over the hub and put it on and take it off each time the hub is accessed and put a new one on. And there's been quite a few studies of this approach, and they've shown that adoption of passive disinfection using the hub cap is associated with a 36% reduction in IPC-related BSI, which is quite impressive. So moving our lens then and thinking about system-wide or at least hospital-wide interventions, I really like the idea of measuring the impact of a nurse-led vascular access team. So this is a collection of studies in a review that have looked at whether and how you can evaluate the impact of a vascular access team. And it's quite powerful that these studies, more often than not, show there is significant impact of implementing a vascular access team. This is just one of those studies looking at the neonatal unit, where they put in place a kind of nurse-led specialist team locally on the neonatal unit, and they found that there were significant improvements in putting the pick in at the first attempt, and needle sticks per attempt were significantly reduced as well, which is great, and also complications were reduced as well. So it was a powerful study that shows that a nurse-led specialist team can really help to reduce the impact of vascular access. This is a nice, an interesting study that was a multi-methods analysis of vascular access teams in the USA using an online survey. Around 77% of hospitals had an on-site vascular access team. I'm not sure how that would look in the UK. Probably similar, maybe a little higher. I'm not sure actually. Interviewees described a broad range of roles that the teams play in terms of device insertion, care and movement education. But there was it was noted that roles in decision making were sometimes limited and occasionally met with physician resistance. So any nurses working in vascular access, I'm sure, will have stories of meeting with physician resistance during their practice. More generally, I think when we're looking at achieving organizational change with anything, it comes down to communication, and sometimes it can feel like we're talking the wrong language and not getting through. In the world of vascular access, if we're thinking about organizational change, we need to communicate with a whole massive group of stakeholders: patients, relatives, infection colleagues, non-infection colleagues, the public, the media, regulators, and the exec and the board. So and more, I'm sure. But there's a diversity of communication skills we need to have to do this. And I'm just going to draw a parallel between getting our message across in general. So this is a piece of work I often think about and point back to in 2015, done by the Wellcome Trust. And they were looking at various ways into talking about antimicrobial resistance. And they found that talking about the big issues, the deaths, the climate change, the economy, were hopelessly ineffective at getting people to really engage in making changes to reduce AMR. But when they started talking about actual bugs, side effects, impact on surgery for you, that's when they began to gain traction. And I think it's kind of summarized in this, that interventions or messaging that talks about the world have least impact. If it talks about our world, then you're getting closer. But if you talk about my world, that's when we begin to land messages. So we need to make it direct, personal, and relevant for people to take notice of our message. Another element to consider is around patient participation in in vascular access. So there's a whole wealth of data around the value and the benefits of involving patients in SSI prevention, becoming partners in their own care. And I think there's a lot of potential for us to do some similar work with vascular access. If you look in the literature, there's not much there for vascular access. So I think there's an opportunity really to think about how we can involve our patients in their own care to improve vascular access. So how do we go about achieving organizational change in the NHS? This is a little loop that I came up with just to think about trying to pull some ideas together. So I think the good place to start is stakeholders. Who are we trying to influence? Is it the exec board? Is it a frontline nurse or doctor or other healthcare professional who's inserting the lines? But what's our target audience? Because the messaging will need to be different. I think piloting and testing of ideas is crucial in order to refine the messaging, to make sure we get that messaging that really hits home in my world. What media are we going to use? Where can we meet people? It may be TikTok videos are required in this day and age, which I know everybody loves to do. We need to evaluate the campaign or whatever program of intervention we're doing, so that we can understand what's worked and what hasn't. And that will help us to secure investment and driven home through whatever leadership we need. So from a vascular access point of view, I think this is what we need to do. We need to put in fewer vascular access devices because many of them are not indicated in the first place. We need to take better care of them when they're in and remove them as soon as possible. And if we can do that, we will have a safer system of care for our patients. We will save money and we will see sustainability benefits as well. And it can be done. This is an example of some strategic improvements that were undertaken in a different hospital. That they did a bundled intervention and undertook a cohort study to reduce the number of PICs per patient they were using. So they were aiming for this idea of one sorry, I said PIC, one peripheral vascular access device per patient. So in the first group, that was the pre-intervention group, only 15% of patients had their one PIC and a high complication rate. Whereas in the second group, 89% of patients got their one PIC and the complication rate was significantly lower. So, and there were some significant cost savings as well. So just an illustration really of what can be done on an organisational level to improve vascular access. So in summary then, we know that vascular access failures are extremely impactful. They have big financial and non-financial impact and cost. And just to zoom in and to remember where we started here, the patient who presented in our ED for a fall, vascular access device they didn't even need, poor care resulted in an infection and the death of that patient. So there's some really, really hard-hitting impact of getting this wrong. On the other hand, some really big, tangible, low-hanging fruit getting this right in terms of safer care, saving money and improving the environment as well. Vascular access is becoming ever more common. It's harder to get right as patients with DIVA increase. Achieving any kind of change in a financially constrained organisation in the NHS is difficult, and it requires leadership, investment, expertise, and considerable tenacity as well. But I'm convinced that if we do improve our care of vascular access devices, it will improve our patient outcomes, it will reduce cost, and deliver a more sustainable system of healthcare. Thank you very much for listening. I'm sorry I couldn't be with you today. I'm currently, hopefully, on my way to Alton Towers with my family because I'm off on holiday. So I hope you enjoy the rest of the day. I'm sorry I couldn't be with you, and hopefully there's a couple of minutes to have some questions about what I've said, and do feel free to drop me a line, contact me if there's anything you'd like to ask. Thank you very much.